Good morning, everyone. This is Jennifer Geisert with Willows, Nebraska. I have 10 o'clock, so we're going to get started today with our assisted living in Nebraska. We have with us three presenters, and I'll go over their bios in just a few minutes. Before we start, we need to just make sure that everyone looks at their email. We have the sign-in sheet that went out after all your other materials, so make sure to get that and have people sign it as you sit around and listen today. But if you want your continuing education for nursing, I need you to sign that. I need a wet signature. Fax that to me or email it to me, and the information for those numbers and email are at the bottom of your sign-in sheet. One other announcement I have is that we will be sending out an evaluation form. That will be sent to each the email that you registered with. We'd like you to please kindly fill that out. It's very short, and that helps us with our knowing how we our learning sessions. And so please just take a minute to do that for us. We do have one change in the handout that you received. We have a duplicate slide, numbers 9 and 10. So just go ahead and go to page 4, I believe it is, at the top of the page. That would be slide 10, and you can just cross that out. But just giving you a heads up on that so you don't get confused during it. And right now, I will go ahead and mute all the lines. Again, we have the chat function if you want to use that. Carrie's going to be kind of watching that, and we'll cover questions at the end. But if you want to go ahead and post something there, please feel free. I will mute the lines and then do our introductions for the bios. So give me 1 second to get these lines muted. If you have a question during the middle that you need to ask, to unmute yourself, you can hit *6. All right, here we go. We're going to mute.
All guests have been muted. You can unmute your line by pressing *6.
All right. We have with us today Heath, Boddy, and also Carol Ernst and Jayne. I'll start with the bio on Heath. He began leading Nebraska Healthcare Association in 2010. He holds his Bachelor of Science in Healthcare Management. Previously, he led the Nebraska Nursing Faculty Board of Directors and served as the Executive Director of Gold Crest Retirement Center in Adams, Nebraska. He's been a nursing home administrator since 1993. As President and CEO of the NHCA, he leads the state's nursing home, assisted living, licensed practical nurse, and hospice associations, as well as the Nebraska Healthcare Foundation. He has served in many roles on the Nebraska Nursing Home Administrators License Board, Rural Medicaid Long-Term Care Reform Task Force, and as a member of the American Healthcare Association's Future Leaders of America. I would also like to say that he is a board of director for Summer of Nebraska, and I know he's going to give us a lot of information from his wealth of knowledge. I'm going to go ahead and tell you about Carol Ernst. She's a native Nebraskan from Columbus, and she is the executive director of Eastmont Towers, a nonprofit continuing care retirement community, and she's been in that role since 2005. She completed undergraduate at Wayne State College and then has her master's degree in educational psychology from the University of Nebraska. Prior to serving at Eastmont, she was employed for 11 years by Rehab Care Group, and that was in Michigan. Also, she is a licensed nursing home administrator, and she will be going over some things with us from her background today and what she does at Eastmont. I'm going to move on to Jayne. She began her education at Northeastern Community College in Norfolk She received her Associate of Science degree in Business Management and Marketing in 2003 and an Associate of Arts degree in Behavioral Science. She also completed a course with the Nebraska Justice Center in Lincoln. She has assisted individuals in management of conflict and alternative methods to dispute resolution. She also has a Bachelor's of Science degree in Behavioral Science from Bellevue. She began working at a senior care center in Pierce, Nebraska in 1987. She's manager of the center for 4 years. She is currently on several different boards and is at the Willows in Neely right now. I am going to turn it over to Heath. Heath, you can start your presentation by unmuting your line at *6. Thank you.
Well, thanks, Jennifer, and good morning, everyone. We're glad you joined us this morning. We're excited to tell you a little bit about what our experiences have shown us and some of the history of assisted living in Nebraska. Well, I realize we have a pretty diverse group on the webinar today, so I thought I might just start by describing a little bit about what assisted living looks like today in Nebraska. So assisted living facilities typically provide, and really at a minimum, housing and meals, and they usually do that in a group setting. It's almost always for adults, and it's usually with folks that are less able to live on their own. Now, assisted living has enough options today that they can provide additional services like personal supportive care, some medication management, social activities, and of course supervision. Now, as we go through today, I think you'll find it interesting or maybe worth knowing that what the Nebraska regulation and how Nebraska defines assisted living. So bear with me just a second. I just want to tell you what the reg says. So Nebraska defines assisted living as a facility where shelter, food, and care are provided for remuneration for a period of more than 24 consecutive hours and to 4 or more people who reside in that facility at a time. And those services, they need the services often due to age, illness, and physical disability. And so as we progress through today, that might be helpful just to know a little bit about what how Nebraska defines assisted living. So bear with me. Let's talk a little bit about the metrics in Nebraska and what assisted living looks like in our state. So today, there's 287 licensed assisted living facilities in the state. 214 of those, or 75%, are certified for Medicaid waiver facilities. Now, what that means is that the people that live there may qualify for Medicaid payment for their assisted living services. And as many of you with your experiences may know, that's an important component for many Nebraskans to have some assistance, especially as they go into a long-term health care setting. 59 or 21% of Nebraska's assisted living facilities provide specialized care for people with dementia or specifically for Alzheimer's care. And again, as we age and we live longer and we know more about dementia, there are more and more folks that need those services. So assisted living could look in a wide variety of ways. Might be a high-rise apartment that would have many residents that live there. They might be a small house that has as few as 4 people. The living units inside can be a single room with its own bathroom. They can be a double room, maybe that shares a bathroom. Those units or those apartments may have full kitchens, or they may have a more limited kitchenette that might just include maybe a microwave and a sink and a small fridge. The buildings themselves can be freestanding, which means they're not attached to anything, or often you'll find them, especially in Nebraska, physically connected maybe to a higher level of care, like a nursing home or an independent living environment. And I think Jayne and Carol are going to talk a little bit more and highlight some of the similarities and the differences between rural and urban as we go through the webinar a little bit later. So let's just talk a little bit about how we got to this point. In the late 90s, assisted living on the national level was gaining a huge amount of momentum, and we were starting to feel that pressure in Nebraska as well. And it seemed that older adults wanted a more desirable option for those who didn't need the ongoing medical care that was often provided in the nursing homes, or at least at a higher level setting. But those folks also needed some assistance with their activities of daily living, some of the bathing and the dressing kind of things, maybe medication management. And at that time in Nebraska, a non-medical facility that provided the shelter, the housing, the meals, the supervision, and the assistance was typically licensed as a board and room, a residential care, or a domiciliary facility. So back in that day, those facilities were often converted houses, older houses, sometimes hotels, They had multiple bedrooms, usually a common kitchen, a common eating and recreational areas. And I would say this, whether they were a wing of a care facility, an old hotel, or a converted house, or something that was different, they really looked a lot different than they do today. The landscape of Nebraska's assisted livings are much different. And, in a lot of ways, probably much better. One thing that seemed to become clear is that the options that we had in the 90s did not seem to be what Nebraska seniors were wanting. They seemed to want places that gave them a little bit of assistance, but still allowed them to have their independence, their privacy, and of course, all of us as consumers want to be able to exercise our ability to have choice. And it seemed to be no different in Nebraska. So in response to that, a collaborative group sat down, and this group was made up of service providers, consumers, folks that made the regulations, folks that worked with paying, Medicaid, the legislatures, and some advocates. They all came together and they wanted to talk about what the care environment looked in Nebraska at that point, what the care environment looked like on the national level, what the options might be, and maybe sit down and start to hammer out what Nebraska would look like in the future. And I'll say that they put in a ton of research and discussion, and the consensus at the end was to develop an assisted living model for Nebraska that was based on a social model. Now, that's an important point of distinction because in contrast it would be a medical model. So Nebraska said a social model was the right thing for us, and they felt that in this model it would allow the individuals that live there to, as we said, what Nebraskans were seeking that they could maintain their independence, and then the whole goal of this group was then work together with the facility to determine what kind of assistance that they might need. The model would also allow individuals who needed more care than what that facility provided to have that, and they could do that through the hiring of a home health agency, because the goal of the group was to make this assisted living that was coming to Nebraska someone's home, or as much of their home as it could be. And so by 2000, assisted living became law in Nebraska, and then they developed the regulations and all the supporting things to create this social model. And they developed the social model by limiting the scope of medical practice that the assisted living facility could exercise. And again, as you hear Carol and Jayne progress through the webinar, that is an important distinction point, that they limited the medical scope of practice that the assisted living staff could exercise. And as you might guess and maybe remember, assisted living Nebraska grew quickly. And I tell you, it wasn't just Nebraska, it was also on the national level. It was a boom if there ever was one. And as you all know in your different environments, that when you have new things and new concepts, often that comes with a few bumps in the road. So in 2003, a diverse group got together and said, all right, let's sit down and look what we did, see how that's working, and then determine if we need to do something different going forward. And so they did that. And again, after lots of thoughtful consideration and again some research about what was happening around the country, what was happening in Nebraska, how was it working, how did consumers feel a bit about it, they decided that maintaining the assisted living as a social model was the right move for Nebraska. They also identified a role for the nurse. But here's another key point of distinction. Just like before, this group really limited the scope of practice for the nurse in the assisted living environment. And Jayne's going to talk some more about that here in a bit, but let me just say this. This point, the limitation of the nurse's role in an assisted living environment, is a point of confusion that we often deal with, whether it be as providers or as the association, with other providers and often with consumers. It's just one of those points that seems to get confusing. Now, in that same revision, they also added some continuing education requirements, and then they finalized all that in about 2004, and again felt that they were on the right path and doing the right thing, and Nebraska was progressing with assisted living. Now, before we continue on, I just thought it might be worth noting a few things. The federal government does not regulate assisted living across the country. So what does that mean? Why is that important? Well, that means that each state can have a very different model. Nebraska, as we've discussed already, is a very social model. You can have other states that are very medical model, and then you have some states that are somewhere in between. And it does create, if you especially live in a community or are looking at a community that's close to a border, it can create confusion depending on which border you're on. It can have there can be a consumer that looks at Nebraska and says, wow, the nurse is very limited in what they can do, and maybe they go to another state and they have a lot more freedom in what they can do. So it is a point that does offer some confusion. Now, in Nebraska, assisted living is licensed and regulated by the Department of Health and Human Services. Other states have other things they call that. They can call it the Department of Aging. It kind of goes all over the board. But here's what I will say. Nebraska's regulations don't require assisted living facilities to provide specific services, but they allow for them to be provided. And again, through the use of home health and things along those lines, that can be done. And so these services we're talking about would be things like medication management, transportation, assistance with the activities of daily living. So we've come a long way, and I think if you were able to see assisted living back in the 90s and what it looked like, specifically what the facilities looked like, I think you'd agree that they're very different today, and it's been an evolution, and I hope that my colleagues that are here with me can talk a little bit about some more things, some distinctions, and then maybe where we're going from here. So let's shift gears just a little bit, and I'll have Jayne start talking a little bit more about Nebraska's assisted living model, maybe what it is and what it isn't. And Jayne, would you take it from here?
Sure. Thank you, Heath. I guess you might think it goes without saying, but it's really important that the residents know and feel that this is their home. That's why I like to call it a home. I don't, more of assisted living exactly, but never a facility. The activities are always scheduled or can be shared with other residents, and if you really don't want to join in on the activities, you can go to your room, your apartment, and just have your own privacy. Each assisted living promotes the resident's self-direction, participation, decision, with emphasis on independence, individuality, privacy, dignity, residential surroundings. With all of that said, I always say resident rights are not just lip service. The resident needs to be assured that this is their home and they get to make the decisions on what's happening, and the employees and even myself, we're just there to help them make it a more home-like environment. Excuse me. I like to always tell families and residents when they come in, I kind of have a Reader's Digest version of what I think a resident should be able to do in this particular apartment or whatever. They need to be able to get to the dining room, manage their incontinence, and not be an elopement risk, because our facility home is not a locked unit. But we do have pendants, which they use like an in-house life alert that the resident does wear or carries with them so they can press if they need something. We are not a hospital and we are not a nursing home. We are not able to do tube feeding, IVs, and it's important to ask these questions of an incoming resident if they are going to need shots or dressing changes, and if this would just be short term, we can have home health come in and help do that. Now, we have medication aids because our building is smaller. We just use medication aids that we have a communication book, and I remind my medication aides, this is a communication book that is important to the residents and the daily happenings. Now, the medication aides also do daily notes in each resident's chart. What we do when a resident goes to a doctor, we send a cover sheet with them so the doctor can put the instructions and comments on that sheet, and we send a copy of the resident's current medications or any notes of issues the resident may be having. We also keep a copy of the resident's Medicare cards, insurance cards, power of attorney papers, and they're kept in an emergency envelope in the resident's chart just in case we have a quick call and we need to send that envelope with them. Now, when the resident goes to the hospital, if they're in there a while, we'll go back and myself or a nurse will go in and do a re-screen to assure that the resident is still an assisted living level of care. We also review the discharge orders, the change of medications, anything that the doctor may have prescribed, just as if your own family member would be going home, because that's what they're doing. So we go over all of those papers the medication aide, myself, and it all goes in the resident's chart. We are fortunate. We do much of our communication through the fax line, because then we also have hard copy of it, and this includes when they go to the doctor's office or to the hospital. We really strive to keep family well informed by phone calls, or even emails. And what I'm finding is a lot of the families appreciate the emails because they're busy and they can shoot those back and forth. Medications, we have 3 out of our 28 residents that do self-medication. But in our particular facility, again, home, in our building, we don't charge extra to have our medication aides administer the medication. So most of them are like, no problem, we'll just do it ourselves. We do have our nurse do a screen on the residents that want to self-medication, because that way we know they're safe and they can do it themselves. This is the part that gets a little complicated because it's the nurse's role. We have staff on duty 24/7 with an awake medication aide, but our building has a part-time RN on staff to review medication administration policies and procedures and to be responsible for the continued education of the medication aides, although she cannot do complex nursing. Now keep that in mind, not every assisted living needs to have an RN on staff, but they need to consult with a registered nurse, again, to review the medication administration policies and procedures and to be responsible for the continued education of the medication aides. It is very nice that our RN is in the building, but sometimes that's where it becomes confusing for our providers and families. We had a resident that needed calcium injections, and the doctor's exact words were, well, you can do that there. No, we cannot, but we can have home health come in and do it. Also, if the assisted living is attached to the nursing home, you cannot use that staff from the nursing home at the same time as you're using it in the assisted living. Again, another part that becomes confusing. Stable and predictable versus complex care. Now, we all know nothing is black and white. Non-complex interventions, which can be safely performed according to the exact directions, which do not require alternation of the standard procedure, and for which the results and resident responses are predictable. Resident needs to be involved in that direct care. We have had providers expect our nurse to remove stitches. Well, that's not stable and not predictable. Here's the thing, especially in the rural areas, sometimes people remove their stitches, and maybe they even do it in the urban areas, but they just remove the stitches at their own home. We cannot do that. What if the stitches would get infected? It gets a lot more complicated, and in all fairness, I know it's confusing for the providers, but it has to be stable and predictable. We also can use hospice services. Again, I'm coming back to home health. We are very fortunate that they could come in and work with the doctor and remove those stitches. We have used hospice services, keeping in mind it requires working very closely with the hospice and the resident, and they will still need to meet the level of care in the assisted living, and that may mean using care providers from hospice. Our building is a smaller building. It's not attached to a nursing home. Smaller buildings, even if they are attached to a nursing home, generally have less rooms. But it's nice. They're closer to home. They're closer to their church, their local activities. We have a couple of our residents that go down and have lunch at the senior center, which is so nice. And I'm sure they can do that in urban areas also. But we may need to travel to 50 miles away if we need more extended care for more intense services, more specialized care. What I also find in the rural areas is finding employees, especially the medication aides. It's tough. And if we're fortunate to have a hospital where we're at, but we also are in we compete sometimes with the employee level. Depending on the size of the assisted living, might determine what your staffing will be. For our building, medication aids work, and we would not need a certified nurse assistant, and we do not hire for the sake of an LPN nurse on duty. We might just hire one because we need that position filled for medications. I think that about covers my part, and I hope if I didn't answer your questions, you'll be able to give them to or ask them at the end, and I would like to pass over to Carol.
Thank you, Jayne. Thank you all for joining us today. There are some real differences between urban and rural areas and facilities, but there's also similarities. And as you've heard, because we are not regulated by federal guidelines, it allows us, the social model allows a lot of variation from facility to facility. And I'll talk a little bit today about maybe some of what you might see in the urban area in our facilities, and I'll talk a little bit about the facility that I work for. And I'm in Lincoln, but suffice it to say, in the Lincoln and Omaha area, and I know this is true in some of the larger towns across Nebraska also, there's a huge variety of assisted living facilities, and they may not all look the same, as Heath indicated. They may look very different. Some people have taken areas of an older building and renovated it and retrofitted it. Some of them have built beautiful new buildings, and some of them are, ground level. Some of them are tower level. In our particular facility, we are a continuum, so we have independent living apartments, about 145 of those, and we have 75 assisted living beds, and we have a nursing facility also. All of that is on the same campus. So that is different than many of the other assisted living facilities in Lincoln. Some are standalone. Some are connected to independent living only. Some of them have the entire continuum. So very different. When people in Lincoln or Omaha go to look for assisted living, they have many, many choices. And we always encourage folks to tour those facilities because there are so many choices. One facility just may not fit the needs of an individual the way another facility fits the needs of an individual. Sometimes in rural areas, you don't have that many choices. On the other hand, your facility in your close, 20 miles down the road, you may know many of the people that are there. You may know many of the staff. You may have lots of connections. You may have been a part of establishing that assisted living facility in the community. Those are some of those benefits that perhaps the larger areas don't have. We have lots of transportation options. We are very close to our, in Lincoln we have 3 hospital campuses, 2 hospitals, and we are close to those. It's easy access. We have trauma. Some of the things that we have here obviously are different and accessible than other areas. On the other hand, let's say we have a family member who lives in Lincoln, but her mother, who is getting elderly and frail, lives still on the farm. And Dad is not as able to take care of her anymore, and she would like her to come to Lincoln to live in an assisted living facility, or both of them to come to Lincoln to live in an assisted living facility. Sometimes that's very intimidating for someone who's used to being on the farm and having to get used to being where there's lots of traffic and lots of buildings and less green space and open space. So for some people, all those choices are overwhelming in some respects. So, there's good and there's bad to that. But, we're part of a large continuum. Down the road, we have a standalone assisted living facility who may take almost entirely Medicaid waiver patients. We're all very different in terms of how many Medicaid waiver patients we may or may not, residents we may or may not be able to take in our facilities. And our facilities all look a little bit different. But I will say, by and large, the facilities today, rural, urban, are really very home-like, very comfortable. Most of them are very warm, and that social model has served us well. We've gotten away from the clinical, cold environment, and again, that has served us well. Some of the challenges in the urban areas are that we do compete with each other for staff, and that is particularly true for med aids. There are many options for med aids in the urban areas, and sometimes if the facility down the road offers 50 cents more an hour, that's enough for the med aid to decide that they want to go elsewhere. So unfortunately, we experience more turnover than we would like because there are many choices in those areas. Also, sometimes when you have that many choices, hospitals make decisions about who they want to partner with in some urban areas, and they may actually exclude partnership with certain assisted livings, and so that's a competitive environment we have to learn to deal with. One of the things I would just like to say also is there is some beauty in the fact that we are all different and we can create our own environment. Some of us are more specialized in memory care, and some of us are not. As Jayne said, I think you said your facility is not secure. My assisted living facility is secure. And so, we may choose to do dementia care. We may choose not to do dementia care. We may choose to integrate dementia residents in with the rest of the population. Every facility, again, is a little bit different. And also how we charge is different. If you look at all the facilities in Lincoln, many of us charge differently. Some have just a base rate with very little variation off of that rate. Some have a base rate with extra charges for supplemental care, perhaps med management, depending on how much assistance they need with their activities of daily living. So very important to ask those kinds of questions when you're looking to go into assisted living. I think that one of the things that becomes confusing is when someone needs to make a transition to and from assisted living. And I think Heath made reference to this, as did Jayne. It can be very confusing. And so one of the things that it's important for the assisted living environment to do is to really communicate what it is they can do, what it is they can't do. And I think a lot of that confusion is many providers, physicians, think of us as a mini skilled nursing facility. We are not. In some states, that is true. That is not true at this point in Nebraska. So we have those limitations in terms of what we can do. And those limitations were very clearly set up in 2000, 2003, 2004, as Heath alluded to, for guidelines to adhere to that social model. So when people come in, we really want to make sure that we get a very complete history and we have forthright communication so that we can really make for a successful transition into assisted living. The same is true when they may need to transition to the hospital, to a nursing home, to back home, whatever the case may be. That complete information and communication is really key and really important. And again, what it is we can do, what it is we can't do, and being able to communicate that to those that are making the transition or helping to make the transition. It's also important to know who is the point person at the assisted living facility. I would imagine in Jayne's facility, she is key. She is key. And she while she's not a nurse, I imagine that you have to do many of your orders from the hospital via fax. and then your consulting nurse helps you, and your med aides help to
Transition back.
help to make that transition back. In my case, we have a consulting nurse that comes in also, and we also have clinic nurses on campus who can come in and help us if we need to at any time. Not all facilities have that nurse on campus at all times, and that is especially true in some of the rural facilities. They may not have access to the nurse being there at all times. In our case, we typically have a nurse on throughout all shifts. Again, that's an exception to the rule for many folks. Also, the fact that we need to have very clear expectations with the resident, with the family, with referral sources, physicians, other providers or caregivers, very clear expectations about who we are, what we can provide, so that coming in, whether it's coming in for the first time to move in or coming back from the hospital, it's very clear what it is we can do and who we are. It's really important for us to be able to analyze those risk factors, and as you know, there are many. I just need to take a minute here to say the people that are in our facilities today are very different than the people that were in our facilities in 2000. And we built our main facility in 2001. And the changes are marked, and they are really, really significant. And part of that is we are seeing more of a move to get people out of the hospitals. And so the people in our nursing homes are far sicker than they were 13, 15, 20 years ago. And the people sometimes that were okay to live in the nursing home long-term environment back then now find it that they can manage well in an assisted living environment with minimal assistance or just some assistance. And that's often preferred for folks because it is so much more home-like. On the other hand, we have people living longer. The average age, it continues to get higher. I know that has been our experience, and their comorbidities are also much more complex. So our population has changed, and we're going to talk a little bit more about that in a second. Very important then for our staff to observe changes that are occurring with our residents, do what we can to prevent issues, and get on board early to make sure that we are paying attention to red flags, things that are happening that are unusual, and the nurse can provide a key role in that case. Now remember, our residents direct their care. And our nurses, at this point in time, even though they're limited in their scope of practice in the assisted living arena, they can still be a great link in helping our residents make choices, educating them about what those choices mean, and just paying attention to those things that are looking like they may need to have early intervention or perhaps have the physician take a look at. Very important for us to involve that home health. Companions play a big role. Our families play a huge role in the assisted living environment, and we really make sure that we engage them as much as possible. And, you know, Jayne made a little bit of a reference to the resident's condition if it's not stable and predictable. So keep in mind, if it's not stable and predictable, we are limited in terms of what we are able to do. Even though I think many times healthcare providers would like us to be able to do some of the things and keep people in our assisted living environments, that's just not always possible. Okay. Just like in 2000 and 2003, when groups of people got together and said, what is assisted living, what do we want it to look like, and how is it working, we are beginning to do that same thing. And part of the reason we're doing that is because there continues to be more and more confusion about what it is we can do. Our population has changed, and many changes are happening just in terms of healthcare in general. So we have begun to establish a coalition to take a look at the future of assisted living in Nebraska. And we are looking at the role of the nurse and what that might need to look like in the future. And we are examining, might that need to change? And this coalition, at this point, started with some nurse leaders in the state, representatives from the Department of Health and Human Services, from Nebraska Board of Nursing, some gerontology nurse leaders, Leading Age, Nebraska Healthcare Association, and Nebraska Assisted Living Association are involved, and some providers are involved. This is a start because we believe we need to do another step back and take a look at what do we want our future to look like. At this point, we're branching out into some subgroups, looking specifically at the role of the nurse and at expectations of our consumers and where we want to go with that. Regulatory changes, we're not sure. We may or may not want to look at changing some of those regulations. That is something that still is out there. But because our population has changed and because expectations have changed, we may need to look at those regulations and see, do they need to be revised? Can we work within the existing regulations? Perhaps that limited medical role and limited role of the nurse is as much of a challenge as anything. So the other thing that we really have to be aware of is that our consumers' expectations are changing. They want to age in place. They like the home-like environment. They would love, if at all possible, to live their last days in that apartment, in that home-like environment. The baby boomers really appreciate that home-like environment for their parents and their loved ones and want us to be able to do more oftentimes. AERP has challenged us to look more at perhaps being able to provide more services and more medical services within the environment. So there's change on the horizon. We're excited about that, and we think that, in the next couple of years, we're going to be able to develop some changes in Nebraska.
Great. Well, as you've heard, let me just do a quick summation here. We've talked a little bit about the model, the setup in Nebraska. Jayne and Carol have both told you about some of the differences in those. Nebraska is a social model. It's resident-directed care here, and that's an important distinction. I think one that even back in the 90s that Nebraskans wanted. And remember that just because there's a nurse on the team in that assisted living, it doesn't mean that they can operate to the full scope of their license, and that's based on the regulatory requirements for the assisted living facility. There are different services that are available. Some facilities want to have some specializations, and some facilities don't. And remember that as specifically today we talk about transitions to and from assisted living, they can be tricky. We like to say around here, if you've seen one assisted living, you've seen one assisted living. And that's a little bit tongue-in-cheek, but the idea with that is that as you look at transitions, whether it be as a provider or whether it be as a consumer, realize that you have to research what each facility offers and what the things they're willing to do and what their talents can do. I did want to say, to follow up a little bit with Carol on the future of assisted living, if anyone on the webinar has an interest in serving on the coalition, if they would reach out through Jennifer at CIMRA, we can put them in touch with the people that are sitting down at a meeting and seeing if we can make that connection for them. Our goal today was to help you know a little bit more about assisted living in Nebraska. And on behalf of Jayne, Carol, and myself and the Nebraska Assisted Living Association, and of course our great friend CIMRA of Nebraska, we thank you for joining us. And we'll be here to answer some questions, but Jennifer, I think we'll hand it back to you.
Hey, Jennifer, this is Carrie. There is a question in the chat, and it's from Cindy Catavine. She says, can people who are diabetic and taking insulin reside in an assisted living center?
I will take this, Jayne. I'll take that one because we actually have 4 diabetics in our building. what they need to do is they need to be aware of what they're doing, and we can, our medication aides can administer, but that we're coming back to the resident needs to direct the care. If somebody wouldn't be able to tell us that they're getting insulin or they're not aware of what's going on, then we wouldn't be able to do it. Again, there's that fine line where there needs to be communication with the family. If a resident's condition is not, if we're noticing something different, they may need to move on to another building, more care than we can do. But to answer the initial question, yes, if the resident is part of the direct care.
Would you two both, this is Heath, would you two both agree that in that situation it can get a little tricky? And so if you have somebody that has spikes and valleys on their blood sugars, somebody that can't test their own blood sugars, or maybe sliding scale insulin, that gets pretty tricky in our environments. Would you guys agree?
Absolutely. Yeah. Absolutely.
And if I may jump in, that's where I really understand it gets tricky for the providers. But you can never say enough about communication, I guess, with anything. But, yeah. I hope that answered your question.
So this is Jennifer. Jayne, you said that the resident would need to be aware of what is going on and directing that care. So if they have a high blood sugar, was the medication aid able to check that blood sugar, or was the resident?
A lot of times with our diabetics, the doctor has given orders that the blood sugar is checked morning, noon, and night. So, and yes, the medication aid can go in and check the blood sugar.
Okay, but then the distinction there then becomes they have to be able to use the doctor's order without interpretation or the resident has to decide what happens from there. So if this, then what? And the key in there is there can be no interpretation, no medical interpretation by the medication in that environment.
Thanks.
So the resident would need to say, my blood sugar is 230. I need to have 3 units of that kind of thing, and then the medication aid is able to draw it up and inject the person?
Yes. Here's the thing about that, though, just to clarify, because of the doctor's order is already going to be written out. It's not going to be interpreted as a sliding scale. The doctor's order is going to say at 7 p.m. before she eats breakfast, she is going to have 3 units. And that's not interpreted by the medication aid. That is a written order from the doctor.
So does it get us, so then are we saying, and this is a point, you can tell this is a point that's always moving, but so then is the ability to test, so let's go back to the medication or the resident test their blood sugar, and they are somebody that has spikes and valleys, but they can handle it. Can we care for them?
If they can direct their care.
Okay.
And actually, this was probably 3 years ago already. I hesitate to even throw this in there because this particular resident was very, very, she chose to live with us, and she would walk up and would say, you know what, check my blood sugar. Well, it's not, nope, I know I'm feeling different. I need my blood sugar tested, and I want somebody there when it's tested. So, like I said, it's so important that resident can be involved.
Absolutely. Absolutely. Resident has to be able to direct that.
Yeah.
And I think this, even though it sounds like maybe we don't have this completely into a definition, it points out again that this complex nursing intervention is the place that this gets confusing. Because Nebraska chose a social model, and because that's the way it's set up today, the medical things that happen there have to be directed by other people than the assisted living staff. So whether that be the resident, the physician, and it's never as easy as yes or no. It just seems like it's always one of those things that we have to work through.
One other thing I'd like to throw in there about this. Sometimes I feel for a couple of my residents, or maybe half of them that are in there, maybe they could be living in that own house, but coming back to that social model, they like somebody that is right outside that door that can come in and say, help me, I need something, or I need that social interaction, but yet I want that stability of if I fall or if my blood, I'm feeling weird and I know it, there's somebody right there that can be there to help.
Makes a huge difference.
Okay, I think we have another question in the chat. Carrie, do you want to?
Sure. The question is, when someone is transferred to or from an assisted living to a hospital or ED, who gives or receives the pertinent information? What role? I guess, what individual's in that role?
Well, if I understand your question, the hospital would call, this is Jayne, smaller rural area again. In my particular situation, they would call our office and they'd say, Jayne, I have somebody up here I think I might want you to come and look at. I think they might fit for your building. And then I would go up and I'd visit with the resident, with the family, and with the nurses in the building. And again, I'm not a nurse. So sometimes that comes down to, I'm fortunate, I do have a nurse on staff, but I will honestly say she does not always do this screen because we're going to need to be able to take care of this resident as people and we can't always say that we're going to have that nurse to do complex interventions.
Correct.
Carol, how does that happen in your environment?
You know, in our environment, we have what would be like a care navigator, and they work with independent living folks, and they work with the assisted living folks to help with the transition. And in that case, it's an RN. And so typically, if it's Monday through Friday, that person will take the orders, and it makes it a little bit easier. And then he or she, is the consultant in that case. So we typically divert all of that that's coming through, whether somebody's going back to their independent living apartment or their assisted living apartment, we divert that through that individual. But that's probably an exception to the rule. So there's usually one point person at our place. That isn't always the case. It may be the med aide saying, could you please fax us that information? And we still get faxed information just like Jayne gets faxed information. We would like to be a little bit more electronically connected than we are, but...
Did that answer the question as we understood it?
I think that might have answered when you're receiving someone back. But what about when, this is Jennifer again, what about when you send someone to the hospital or you're sending someone out to the emergency room? Do you guys, I know you said you send like a cover sheet and the meds, what else goes with and who might be filling out that information? I think if we could cover when you send someone to the hospital, who does that, whose role is that, and what is sent?
Okay, this is Jayne again, and we kind of have it's a rule. When in doubt, if you're there and you can't call 911. I mean, and we have an emergency envelope ready in every resident's chart that has insurance paper, power of attorney papers, who to contact. That's already made up. So by the time you call 911, you make a copy of the medications that they're on. By the time the ambulance gets there, then all of that information goes with the resident to the hospital.
Now, what if it's an expected event? So that would probably talk about an unexpected event. What if the doctor said things are changing with the resident, and so how would that work? Would the physician then direct that, but then you would help coordinate, you and your staff would help coordinate that?
You mean if the resident had a doctor's appointment? Or?
No, I mean if something was going on with the resident and the doctor said it's time to admit to the hospital.
Oh, yeah, basically the same procedure would happen, except if it wasn't an emergency, like then one of our medication aides would take the resident to the hospital, but all that same information would go along. We try to give as much information so that the nurses, when they're admitted to the hospital, have the information.
Very, very similar. Very similar. One of the differences would be we often have our own transportation. If they're, able and it's not emergent, we can transfer them in our wheelchair van. But very similar to what you're doing.
It's interesting though. Again, with rural, when I think about, we're very fortunate to have a lot of our family members involved. But they may live 20 miles away, so you're getting on the phone with them so they can meet the resident at the hospital. Although I have one resident that his closest family member is in Tennessee, so we kind of take him, and to answer this question, we all just take him under our wing. Nobody leaves him up at the hospital by themselves. So in that particular case, until he was admitted to the hospital or whatever, myself or a medication aide would stay with him just because, he doesn't have any family members close.
And Jennifer, as it relates to timing, when you talk especially about a discharge, one interesting thing also worth noting is that in the rural areas, you're often dealing with a volunteer ambulance crew, which can be people that work in that small town, maybe farmers in the area, maybe people that stay at home. When you work in the city, you have a lot more, or in the urban areas, you have a lot more connections. As Carol talked about transportation, there is ambulance services that all they do is transportation. So it does make a big difference in the speed and in how that transition works. And I would assume from the receiving entity, it makes a heck of a difference in how that all plays out.
Yes, again, those are all, all the differences within the different communities and rural situations. I think, having worked with care transitions at Summerall, Nebraska now for a couple years, I guess getting at how is the information communicated and what information is communicated. Is there a way that you guys communicate what is currently going on with the patient, what led up to this transfer to the hospital ER? Is there like a summary or anything that goes?
Jennifer, this is Jayne again. We have, it's what I guess a standard form, and say hindsight here, I wish I almost would have given you that form ahead of time. There's lines in there that we can, maybe I missed it in my part of it, but the medication aides do charge, if somebody's been a little sad or something's going on, then those notes might actually go with the doctor's appointment with them. But we do have a standard form, resident's name, doctor's name, what's going on, and then a pretty long list that we want the doctor to make the notes on, and then he or she signs dates, and then, that's really, we keep all of that, and that's critical that we have all of that in our form. The other thing I just wanted to mention was we've been working really hard on when a resident goes to the hospital, and then we'll go up and look at the resident again. But what comes home, what comes home with them, and I always kind of laugh about this, because if the resident was going back to their own house by themselves, I would think how complicated some of that would be. Because this is maybe what you're asking, we actually have at least 2 people double check those orders that come back from the hospital with that resident, just to assure that we're not missing something.
Maybe duplicate meds or treatment. Okay.
Yeah.
And I think also we also do a summary, and we do try to if we've noted differences that have been happening with mood, with behavior, physical changes, we do try to make that summary and send that with. In fact, we even do that oftentimes when they go to their physician. We have a form, as Jayne said, and we fill that out so that the physician is aware of some of what we have been seeing and some of the changes and some of our concerns. So it's not only when they're hospitalized, but also when they're seeing their primary care physician or a specialty care physician.
And in my experience, and you can tell me if this is still what you're experiencing, but when you use an emergent situation, then not only whatever information can you give, the ambulance team as it may be, then they'll also write up their own documentation as they're going. So there would be,
yes.
I don't know if more is the right word, but maybe some different documentation.
One other thing that, just as Heath was talking, we also we require an advance directive when a resident comes into our building, and we keep a copy of that, and that also goes with the emergency, doctor has that on file, but if there's an emergency situation, that's also in that envelope, so the ambulance knows.
And I think most facilities practice similarly.
All right. I see that we are past the top of the hour. I want to thank everyone for joining us today and to thank Heath and Carol and Jayne especially for giving us all this information. It was a wonderful, wonderful opportunity for, I know, our providers to learn more about assisted living. And we will make this recording available. It'll probably go on our website at Sunrose, Nebraska within 2 weeks. So if there are other people that you know at your facilities, hospitals that would learn from this, please share that link with them. Also, we'll send out that email with the survey. I want to thank everyone for joining us. I'm sorry we've run out of time, but if you have further questions, you can send those to me, Jennifer Geiser at Simro, and that's on the bottom of that sign-in sheet, and I can forward them on to the presenters. Thanks, everyone. Have a great day.